Welcome to the top 6 controversies in the dementia field. My name's Sally Smith, and I'll be moderating today's webinar. It's my pleasure to introduce you to Tami Anastasia. Tami is a dementia consultant, educator, and speaker. She's also the author of the acclaimed book, Essential Strategies for the Dementia Caregiver, Learning to Pace Yourself. Tami holds a Master of Arts in Counseling, a certificate in gerontology, and a certificate in end of life. She's also a certified senior advisor. For more than 30 years, Tami has provided counseling services, dementia guidance, emotional support, and care strategies to family and professional dementia caregivers. She also facilitates twice monthly support groups. Please join me in welcoming Tami.
Hello, Sally. Thank you, everybody, for joining us today. And today I'm going to discuss the top 6 controversies in the dementia field that I encounter in my private practice. So today we're going to discuss the use of restraints, the use of antipsychotic medications, the use of life-prolonging treatments, sexual relationships in care communities, surveillance, and therapeutic fibbing. I would like for all of you to remember and to keep in mind that the families are coming to us for guidance, support, and advice. And we need to be mindful and very aware of our own biases and those of others, their biases, their cultural beliefs, and religious practices. So this is something as an elder care professional that I think is ongoing, that we just constantly have to keep tabs on what our biases are so we don't impose them on others, especially when it comes to some controversial issues. So I'm going to begin my presentation by going over a vignette on restraints. A 78-year-old man with advanced dementia has been showing increasingly aggressive behavior, particularly at night, attempting to get out of bed and hitting caregivers. The care team is concerned about his safety as well as the safety of others in the care community. The team is considering using physical restraints at night to prevent him from falling or harming others. How would you approach this situation? So Sally's going to put up a little survey, and we'd like to hear from you what your thoughts are.
If you have the latest version of the Zoom client, you should be able to see the poll pop up, and you might have to scroll down. There are 5 choices, so choose the one that most resonates for you. You should also know that the responses are completely anonymous, so we're not tracking your responses. So by all means, feel comfortable in responding. Looks like almost half of you now have responded. We'll leave the poll open for another minute or a few seconds to give you all a chance to weigh in. Okay, oh, it looks like a couple more people are answering. Wonderful. Liz says that she chose before she knew to scroll down for more choices. Totally fine. Totally fine. We'll be doing several of these polls, and you'll have lots of chances to weigh in. Okay, I'm going to go ahead and end the poll, and let's see what the results are.
Okay, well, we have mixed results. 4% said use physical restraints at night as a short-term solution. And then we have 39% said implement de-escalation techniques during the evening to reduce aggression and create a calming environment, avoiding the need for restraints. And then there was 13% said explore medication adjustments. And then we have 30% said to introduce environmental modifications such as bed alarms, motion sensors, or padded surroundings to ensure safety without restraining the person. Thank you, everybody, for chiming in on that. So next, I do want to talk a little bit about restraints. So restraints are often used to protect and control a person's behavior. There's two types, most common types of restraints, the use of physical restraints and chemical restraints. The ethical issue becomes when using restraints, we are infringing on the person's right to autonomy and dignity in order to protect their safety, in order to protect them. What we need to be aware of, and I think the controversy is about overusing restraints. So one of the concerns is that we are overusing restraints unnecessarily and possibly prematurely. And instead of looking at exploring non-restrictive ways of dealing with behaviors, and are we not looking at underlying causes or triggers? Very important that if we're going to use restraints, are we using them prematurely? Are we using them unnecessarily? So factors to consider is that we have alternatives to restraints. We have de-escalation techniques, train people on how to de-escalate a very aggressive situation if possible. Soothing voice, soothing, calming, nurturing demeanor. Then we have environmental modifications. What can we change in the environment? What could be causing or contributing to their aggressive behavior? What could be happening? Is it something that's being said? Is it the environment? But I think it's super, super important that we explore the triggers and just not use restraints as a simple quick fix solution, because the more we understand what's triggering the behavior, the more equipped we're going to be in order to deal with those behaviors. And then we have person-centered care. I think we have to spend more time really understanding the person, their personal history, their likes, their dislikes, their preferences. And again, understanding what those triggers might be or what needs might be unmet. So next, we're going to do a poll on restraints. Quick poll. Do you believe physical restraints should be used in dementia care to prevent harm in cases of aggressive behavior? I'd like to hear what you all think.
And remember, you might have to scroll down to see all the choices.
Right, there's about 5 choices on each of the polls.
Okay, we're getting lots of responses. Great. Okay, so I'm going to close the poll and let's see how you all answered. Looks like about 40% of folks said yes, but only after all non-restraint options have been exhausted. 32% said no, physical restraint should never be used, even in extreme cases. 16% said it depends on the person with dementia's specific situation and needs, and 12% said only if combined with regular reviews to assess whether restraints are still necessary.
Okay, thank you so much for that information. So you can see there's not a one size fits all. It's not a black or white. There's a lot of factors that have to be considered before we just use restraints just to use restraints. So thank you all for doing that poll.
Yes,
Okay,
and
next.
I do. I'm sorry. I just wanted to say, input. It's because we're dealing with people with dementia
Mhm.
and Alzheimer's. So it's like they have no understanding of any of it.
Mhm.
and we do
Right.
as providers.
Right.
So, personally, I don't think any restraints should be done
And I
because
think there's
it's
several people who feel
unethical.
the same way as you do. Absolutely. Okay, thank you so much for sharing that. Okay, next we're going to do a vignette on antipsychotics. A 78-year-old man with advanced dementia has been exhibiting frequent aggressive outbursts, including hitting caregivers and other residents in his care community. Non-drug approaches like routine changes and calming activities have not been effective. His caregiver suggests trying an antipsychotic medication to manage his aggression. What would you do next? And we're going to put up that survey, and there's 4 choices on that.
Okay. We are going to go ahead and end the poll, and let's see what folks had to say.
Okay, 61% said conduct a deeper assessment of potential triggers before deciding. 25% said explore other non-drug alternatives, such as environmental changes. And there's 14% who did say start the person on a low dose of antipsychotic medication immediately. Thank you all for doing that. And next, I want to talk a little bit about antipsychotic medications. Sorry about this over here. My dancing the slide is slow. Okay, let me talk to you a little bit about antipsychotic medications. Antipsychotic medications are often used to treat severe behavioral issues and mood swings. But keep in mind, originally, antipsychotic medications were created to treat schizophrenia and bipolar, and they weren't designed or created to treat dementia. However, we do use them in dementia care because it can ease aggression and agitation. What you also want to keep in mind is that antipsychotic medications affect the neurotransmitters of the brain. And with people with dementia, the neurotransmitters are already compromised because of what dementia is doing to the damage dementia is doing to the brain. So we have to keep in mind when we're working with antipsychotics that it increased the risk of stroke, heart attacks, brain bleeds, diabetes, and in some cases, a 2 to 4% increase in mortality. So this is super important to keep in mind. So if we're going to prescribe antipsychotic medication, it's important also to be aware of the side effects because they can really slog a person out. And this can increase other issues. It could increase the risk of falls. They're hardly awake. Increase confusion. And we also need to be aware that it can also have a paradoxical effect. And in some cases, it can actually increase agitation and anxiety. So the ethical issues here, I think, is dealing with deciding if the medication is absolutely necessary versus the risk of increasing their mortality, increasing and dealing with the adverse side effects. So what I think is super important, and most of you answered this in the survey, and that is all behaviors are a form of communication. All behaviors serve a purpose. With people with dementia, things get compromised and the brain is impaired and they can't communicate clearly what it is we might need to know, and it's expressed in their behavior. And I think it's super important that we explore what could be potential triggers. For as unpredictable as dementia is, there are times where behaviors have triggers and patterns, and there are specific causes. And if we can identify what those triggers are, then here again, we're going to be more equipped on how to deal with those behaviors in a respectful and dignified manner. So what are different? Some triggers. Some triggers could be pain. Some triggers could be our tone of voice, our facial expressions. Some triggers could be that they're reliving a past experience. Some triggers could be boredom, overstimulation. I just want us to
Or
really
they have like a
think
UTI going on.
twice about just prescribing as a quick fix and truly think about what could be contributing to the behavior that we are seeing and observing. If we do prescribe medication, I think we need to tread cautiously. And that is, we need to start with a very small, lowest dose and see how their body, see how they acclimate to the medication and possibly adjust as needed. Then I also think we need to monitor the side effects. So one of the things I encourage my private clients to do is once we introduce a medication, we write it down, we say what the medication is, the milligrams, how much they're taking, and the frequency in which they take it, and we start observing and monitoring the behavior. And then just because we put them on the medication to deal with a behavior, at some point, is that medication still going to be necessary? Is it still necessary on antipsychotic? If possible, we figure out the triggers, and now we can be better equipped on how to deal with and manage those behaviors. So I'm going to give you an example. So there's a client that I'm working with, and her mother has been a pacer, and she walks and walks and walks and walks and walks and walks and walks. But all of a sudden, she's starting to get even a little more agitated. So they put her on Seroquel. By the way, a few of the antipsychotic medications that are commonly used with people with dementia: Seroquel, Zyprexa, Depakote, and now Rexulti. Those are the ones I hear the most of. Anyway, so they started put her mother on the Seroquel. All of a sudden, when they went to visit her, she could hardly keep her eyes open. The care community noticed that she was having a hard time keeping her eyes open, and she's losing a significant amount of weight. So we, did a full workup. There's no real true explanation as to why she's losing a lot of weight. Well, could the side effects of Seroquel be that she's losing her appetite? Possibly. So the decision was made now to cut back on the Seroquel, and she is now up, walking around, and her appetite has come back. So I think it's really, really important that if we're going to use antipsychotic medications, we really pay attention to the behaviors, because sometimes antipsychotic may be right for some, and it may not be right for others. So we have another poll on antipsychotics. Do you believe the benefits of prescribing antipsychotic medications outweigh the risks for people with severe behavioral symptoms related to dementia? We have 5 choices here.
So if you don't see all the choices, make sure to scroll down. Okay, let's give folks just a few more seconds to log their responses. Okay, I'm going to go ahead and close the poll, and let's see what y'all said.
Okay. 61% yes, but only when other treatments have failed and symptoms are severely impacting quality of life. Then we have 18% no, non-pharmacological intervention should be prioritized before considering antipsychotics. 7% said no, the risks generally outweigh the benefits. We have 11% said yes, but only in very specific cases. And there is 4% that said yes, the benefits usually outweigh the risks. Thank you so much for doing this. What I'm really enjoying is seeing the results of the polls. So thank you all for participating in the polls. Okay, next. Next, I am going to talk about a vignette with life-prolonging treatments. A 90-year-old woman with late-stage dementia is no longer able to communicate or eat without assistance. Her family insists on continuing life-prolonging treatments, including feeding tubes and IV fluids, even though her healthcare team has suggested focusing on comfort care. How would you handle the situation? And we do have 5 choices.
Leslie asked, how will the responses to these polls today be used? We're just using them to as a point of discussion. They're all anonymous. The responses are anonymous, so they won't be used beyond that.
No, it's more for our information, just to see where you all stand, what your thoughts are. And more importantly, to see the differences in opinion, right? There's not, again, one size fits all. There's not a perfect answer for any of these. But what I love about this is really, it shows the different options. It expands our thinking. It expands what the options can be.
We're still getting just a few more responses in. Okay, I'm going to go ahead and close the poll, and let's see the results.
Okay, so 48% said encourage a family meeting to discuss the person's quality of life and explore alternatives like comfort care. Then 26% of you said honor the person's advance directive if available, regardless of family opinion. And then let's see, 4% said respect the family's wishes and continue life-prolonging treatments. And then 7% said suggest a trial period of comfort care while reassuring the family that treatments can be adjusted based on the person's conditions and their preferences. And then 15% said facilitate a second medical opinion to provide the family with additional perspectives on the person's prognosis and care options. Okay, thank you all for that. See, there's just so many different opinions. Okay, all right. So for family caregivers, this is a deeply sensitive, emotional, and difficult decision to choose between, do we extend life or do we focus on quality of life and allow their loved one to pass peacefully without any medical interventions? This is not a decision that is made lightly. As a matter of fact, in my practice, it is a decision that is really heart-wrenching for many families. And this is where we have to be very, very, very aware of our own biases and not project onto them, but really support them in this decision, because it is a very, very, very difficult and hard decision. And there's a lot of guilt around having to make these decisions. So I think it's really important that we really get to know more about the people we're working with, the persons, what the person's wishes were, make choices that do align with the person's best interest and dignity, and respect those wishes, but they're not easy decisions by any means. Right now, I do have a client that I'm working with, and her gut tells her, I should just put him on hospice, her father. He's experiencing some medical conditions, 91 years old, advanced dementia. However, the doctors have a different opinion. So what can complicate this decision for family caregivers is when doctors have different opinions than the families. And this makes it really challenging and difficult. So I'm going to share with you a couple examples that occurred in my private practice. So there's two sisters been taking care of their mother, 88 years old, advanced dementia, and she broke a hip. And mom's quality of life was really getting very diminished. So both of them were on the same page, decided we're not going to do hip surgery, and everybody was very supportive. However, the orthopedic surgeon was not. Orthopedic surgeon said, you know, I can do that hip surgery, repair your mother's hip, and I can get her back up and walking. Well, a couple things we want to keep in mind. First of all, she had advanced dementia. The reason she fell in the first place is because she forgot she needs to use a walker. But this made them really doubt and second guess their choices. And here again, you know, clients are coming to us for our support. They're coming to us for advice. They're coming to us to help them make the best decision possible given the circumstances. So we just want to be aware of how what we say to them can have an impact on their decision making. Another one, this is very recent actually. I have a client, her mother, 94 years old, and very active, very, very, very active. At 91, she is climbing a ladder and cleaning the leaves out of her the house. What do you call those up there? Anyway, cleaning the leaves out of
Better.
and so 93, she got a diagnosis of breast cancer. And they decided, well, we're not going to do anything invasive, but we'll go ahead and start her on medication to treat the breast cancer. Fast forward at 94, all of a sudden, mom, who's been very, very active, is now not wanting to get out of bed. So my client comes to see me. She says, you know, Tami, what do you think? Is this just advanced dementia? I said, no, it's out of character for your mother. Something else must be going on. I said, why don't we get an x-ray and see what's going on? The mother had said that she had taken a bad fall, but she couldn't explain it. She couldn't explain when it was, but the mother kept communicating to my client, you know, that fall was hard. The fall hurt. So sure enough, we did take mom, and sure enough, there was a hairline fracture in her spine. So there's a procedure called chiroplasty, and it's least invasive. And the daughter was on the fence. Do we treat it? Do we treat it? So in the process, it turns out that her breast cancer has metastasized and now is spreaded. So they do the chiroplasty, and then the oncologist says, you know, I can go ahead and treat the cancer for your mother. And my client and her family declined, said, no, my mother's quality of life has really changed and we're going to decide against it. And the physician said to her, well, then why don't we just move your mother next door to the room next door and just let her sit there and rot and she'll die in 2 days. So we got to really, you know, we got to really support the decisions that some of these families are making. So the outcome of that story is that we moved her to a board and care home, had fabulous care, and died 3 weeks later. And then this one is a very interesting situation too. So in one of my support groups, what came up is that the wife and the mother of the kids, so the kids and the husband used to come to my support group, the pacemaker battery needed to be changed. Mom was, I think, 79, 80 years old, and the dementia had progressed. And they had this difficult decision to make. Do we go ahead and change the battery in the pacemaker, or do we not do it? So we went around the room. I was curious to see what everybody's response would be. We had 24 people attend that support group. 22 people raised their hand and said they would not change the battery. And to tell you the truth, they decided not to change the battery. So, you know, now I have other clients where they have treated cancer and they pursued it, and it has had an impact on the loved one with dementia. Their life has not been the same, but that's what they felt they had to do. So when we are dealing with life-prolonging treatment and making this excruciating decision, hard decision, difficult decision for many families, it is very hard to make that decision of, do we choose extending life or do we focus on quality of life? So here's where advanced directives can be so incredibly invaluable and can be a gift to the families. As professionals in the elder care world, we can try to nurture and help maybe facilitate having these difficult discussions. So when family caregivers get to this point, we have an advanced directive that states what the person's wishes and what their desires are for end of life can just make a huge difference. It's already a tough decision to make, but having that advanced directive can be incredibly powerful and really gives the caregiver peace of mind, more peace of mind, knowing that they're honoring what their loved one's wishes are. And then I also think as elder care professionals, it's really important for us to educate and us get educated more and educate family caregivers and families on end-of-life nutrition. As the body shuts down, the body needs less and less and less food. And for families, this can just freak them out and they feel like they're starving their loved one, that somehow they're depriving them of nutrients that are going to keep them alive. And I think educating people on what happens at end of life, we can help normalize and bring some peace to the end of life, that we are not starving, we are not depriving their loved one of any nutrition value. It's just that the body is winding down, the body is starting to shut down, and it doesn't require a lot of food at this time. And we're just going to naturally let the body do what it needs to do. So those are some things I think we can do as professionals to help navigate and massage this end of life decision for people caring for loved ones with dementia. So we do,
Tammy,
yes,
we have a couple of comments that I think
yes,
would be good to talk about.
please.
Karen says, professional care managers need to advocate for specific advanced directive documents like POLST before dementia diagnosis. If too late for that, POAs can sign the POLST form. It's ridiculous to do invasive care that causes suffering on folks who have advanced dementia. Families need to be educated about quality versus quantity of life. The costs are extraordinary for much end-of-life care. We are kinder to animals at the end of life.
Sure. Thank you so much, Karen, for sharing that. Thank you, thank you.
And then Leslie asks, who decides the point at which hospice is brought into a client's or patient's situation?
Right, so that's a great question, right? So sometimes in this case that I just talked about, the daughter with the father, she wants to pull in hospice. The doctor said, well, I think it's premature. I don't think we need to pull in hospice right now. So who makes that decision? Well, sometimes doctors will be able to say, you know what? Now we're looking at comfort care, end of life care. But when there's that discrepancy, who is it, the doctor or is it the families? And ultimately, I think the families know their loved one better than anybody, and they need to honor what they think would be the best decisions that align with the person's preferences, desires, what they know about their person. Sometimes I say to my clients when this decision is challenging because, again, the doctor and the person with the family caregiver is different. Sometimes I say, what if your loved one could have an out-of-body experience and they could look down? What do you think they would tell you that they want? What do you think they might say to you? And sometimes they ponder that, and they think, wow, I think I know what they would want and what they would say. So again, as you can see, there's a lot of differences of opinion, not right, not wrong, but making these decisions that are going to be of most support and comfort for the person living with dementia and the families that have to make these decisions, these hard decisions. So Sally, thank you so much. Karen, thank you so much. And anything else, Sally?
Yeah, one more. Nisha points out family has the right to request hospice evaluation at any time.
Great. So good information to have. I did share that with my client who's currently going through it. And hospice acted so fast that they said, okay, we'll go. They came out and they said, okay, we're ready to, take your father back home and we'll get hospice set up. And my client was so overwhelmed that they acted so fast. He goes, wait. I don't even know what the discharge plans and I'm not even sure what. And so it's true. Hospice, I'm just going to say this. To me, hospice are angels from heaven. The service you provide is a gift to the universe. So thank you all who do work with hospice and provide this end of life support and care.
And
Okay,
Karen says, I often have my clients on palliative care as they are experiencing several chronic conditions, and the transition to hospice is much easier for families to understand and accept.
very good point. Excellent point. So thank you again for that as well. Thank you all for sharing. Sally, anything else? Yep, great points. All good food for thought. Okay, so let's do a quick poll. When caring for those with dementia at the end of life, should the focus be more on extending life or quality of life? There are 5 choices, so you may need to scroll down.
Okay, let's see. Okay, I'm going to go ahead and close the poll and let's see the results.
Okay, 44% said it depends on the person's specific situations and wishes. And 33% said focus on comfort care, allowing natural death without aggressive interventions. And 22% said primarily on quality of life. Okay, great information to have. Okay, next I am going to do a vignette on sexual relationships. In a dementia care community, 2 residents have formed a romantic and physical relationship. The family of one of the residents expresses concerns about whether their loved one can give proper consent. What would you do? Oh, and here we have 5 choices as well, so be sure to scroll down.
Okay, we're going to go ahead and close the poll and let's see the results.
Okay, believe it or not, there's result on each one. 48% said arrange a meeting with the care team and family to discuss the resident's emotional well-being and assess the situation collaboratively. And then 31% said monitor the relationship closely for signs of distress or changes in behavior while providing support and ensuring the resident's safety. And then 7% said involve the family in further discussions, but prioritize the residents' autonomy. And then 2%, 3% said support the relationship and assess the ability of both individuals to consent. Okay, thank you all for that. All right, say a few words about sexual relationships. I think, again, reflecting on my private practice, one of the things we need to do is to normalize and recognize that just because a person has dementia, that they may still have sexual needs, desires, wishes, wants. And a lot of times I think families think, well, since my loved one has dementia, that goes away. It does not go away. And it's something that I know in my private practice, I have to normalize and bring to their attention. And so when I talk to them about that, they say, well, but I'm not with them, especially if we put them in a care community. And I said, it's just something I want you to be aware of, that they may find interest in another person and try to educate the families about this and prepare them in case it should happen, because it is something that happens frequently. And I'll share a couple stories. So I think it's important that as professionals that we do our best to educate and let families know that this is something that can continue. And in some cases, really, sometimes those sexual wants, needs, and desires can really increase. I think that, consent is a huge issue because we're dealing with people with cognitive impairment. And so the question I ask is it okay for two people with dementia to be in a physical, sexual relationship if they are happy and it enhances their quality of life? So I have a client where a physician referred me to see this client. This client had severe depression, was very depressed, which is why I went out and I would visit with her weekly. And for about a year, regularly, I would go out and visit with her weekly. Then about a year and a half into it, all of a sudden she met this man at the care community. And wow, she came to life. She was happy. She was, she was she was just in such a better spirit to have this man who was attentive to her. And we would talk, when we go on our walks or we go to the park, and she would talk to me about this relationship she had with this gentleman. She'd tell me things that she didn't like about him and what made her mad about him. And there were times where I would go there, and I went by every week, same time, same day, and I would walk in on them. And I just said, oh, excuse me, listen, I'm here. So whenever you're ready, I'm ready for you whenever you're ready. Didn't make a big deal about it, just kept it very low key. And I have to say, it really did enhance her quality of life, and it just made her feel good that somebody was caring and loved her. Now on the opposite end, I have a client and he just placed his wife at a care community. And his wife got to the point where she didn't really recognize him. And one day he went to the care community and saw his wife holding hands with another gentleman. And my client came in really just emotionally a wreck and just said, I can't believe my eyes. My wife is holding hands with another man. And we talked a lot about, that. And I would say after about 3, 4 different sessions, one day he came into my office and he said, hey, Tami, I've got something to share with you. And I said, well, what's that? And he said, I saw the most beautiful thing today. And I said, what is that? I saw my wife holding hands with a gentleman that made her happy. She may not recognize who I am, but I understand better. And we were able to process that loss for him about his wife and the relationship he had with her. So I think it's important that we educate family members that these things can happen. The flip side of that is that, in a care community, we always want to protect them, make sure that they're not being taken advantage of. And it probably also we have to consider, how far is the dementia progressed in both individuals. So the care communities have to be able to respect the rights of being in a sexual relationship, and at the same time monitor that the person is protected and they're safe. The one more story, and this one I get mostly from the wives. I cannot tell you how many phone calls I have gotten, and the wives come in and they're like, their husbands can't have enough sex and the wives are so not interested. And they're like, how do I deal with this, Tami? What do I do? So I wanted to give you a couple different perspectives on how to think about sexual relationships with people with dementia. And again, I think the care communities, it's a delicate balance between honoring the individual rights to be in a sexual relationship and at the same time make sure that they're protected and not being taken advantage of. So I think care communities, when you do tours or, you're talking to the families, I think this is something that we definitely want to bring to the surface, that bring to their awareness that this is something that can happen, because sometimes they're in such shock, and in some ways they're just like, oh my God, they don't know how to handle it and don't know how to react to it. The more clear policies you have about sexual relationships, and I think we also have to educate staff on how to deal with these sensitive issues, because we don't want them to make a big deal and blow it out of proportion and then it gets everybody upset. So I think it's just, things that we have to consider, that it does occur, it does happen, and not to deny that it doesn't exist, rather than bring it to the table, bring it to people's awareness so we can plan and prepare for it if it should happen. So I have,
Tammy,
yeah.
I'm sorry. David says the recurring theme in the probate code is, quote, least restrictive, even for people with dementia. Theoretically, a conserved person with dementia can get married unless there is an order to the contrary.
Thank you, David, for that. Okay.
And then, wait, I'm sorry.
Yeah.
Earlier, I accidentally skipped over it. He said, and I think this was, gosh, I'm not sure if this is about, I think this is about prolonging life. He says, as we answer these questions, what is our decision-making role? Are we in a legal role like a healthcare POA or the conservator? And then Leslie responded to that and said, some of us as professional fiduciaries have legal responsibility to carry through on the written wishes of our clients.
Okay, so here again, various opinions depending on the role, depending on what you do for a living and the purpose you serve and the role you play in the people's lives who are taking care of people with dementia. So thank you so much for sharing all that great information, everybody. Okay, quick poll. How should care communities approach sexual relationships between residents with dementia?
Okay, we're going to go ahead and end the poll, and here are the results.
Okay, 79% said encourage open communication between residents, families, and care teams to address concerns while respecting residents' autonomy. 4% said it did depend on the level of cognitive impairment of both individuals. 4% also said involve family members to normalize that people with dementia still have these needs. And then 11% said allow relationships as long as there are no signs of harm or distress. And then 4% said only allow relationships with clear documented consent from both parties. Thank you again, everybody, for participating in that poll. And again, you can see different opinions. Okay. Next, I'm going to do a vignette on surveillance. A 75-year-old man with mild to moderate dementia has recently started wandering outside of his home, posing a safety risk. He refuses in-home care. The family wants to implement a GPS tracker and place security cameras in his home to monitor his movements. How would you approach the situation? Again, there's 5 choices.
Okay, we'll give it a few more seconds. Okay, we'll end the poll and let's see what you all said.
80% said consult the geriatric care specialist to develop a comprehensive person-centered safety plan that respects the man's autonomy while addressing the safety concerns. 8% said use the GPS tracker, but limit camera use to avoid infringing on the man's privacy within his home. And 12% said discuss the situation with the man to understand his comfort level with tracking and monitoring. Okay, thank you for doing that. All right, so we'll talk about surveillance. Surveillance is used to monitor the safety of the person living with dementia. And there's invasive and least invasive ways to do that. So a couple, there's GPS trackers, there's the little tiles that we can put in the clothing, the pockets, the shoes, their wallets, purses. We have cameras, monitoring systems, electronic door alarms. We also have radio frequency identification technology that's worn by the person with dementia, and these tags interact with sensors placed around the care community to track movement and to ensure safety. We have mobile apps, bed and chair sensors, and baby monitors. I just learned something very interesting. Don't know if all hospitals are doing this, but I have a friend whose mother got COVID, and they put her in isolation and put her in a private room, and they have a baby monitor in her room to watch her movements and behavior. So that was new to me. Maybe that's something that's been going on, but I didn't know that hospitals started doing that with COVID patients. Okay, so here again, what's the ethical issue, Will, is weighing the benefits of safety and monitoring their safety and versus the right to their privacy. So this comes up a lot in my private practice, and it comes up a lot mainly with the person with dementia is living alone and is not aware of their limitations and refuses to bring in home care and refuses to go to a care community. And so the family and I discussed different ways to monitor the safety of the person. And we do sometimes put cameras into the home to monitor what happens. And I have to honestly say that in some cases, it's really truly been a lifesaver. We've seen several people with dementia take a bad fall, and the families were able to call 911 to go out to the home. They met the 911 out at the home. We've also, with GPS trackers, have been able to find people who've gotten lost, who've been wandering. And also we've seen some microwaves catch on fire. So some people look at this as could be monitoring their safety be a compromise between, since honoring and respecting their wishes, they don't want people coming into the home and don't want to go to a care community. Can this be perceived as being a compromise in terms of honoring the wishes and allowing this person to live as independently for as long as possible? It's short term. It's not something that can be sustained because, as we all know, dementia progresses. So the other challenge here is getting the consent from a person who has dementia when they don't see their limitations. So this makes it very challenging for families to determine what to do. And again, the options often are bring in home care, move them to a care community, and some families are opting to monitoring their safety by putting in surveillance cameras or GPS trackers. In care communities, I think it's important here again, get the consent obviously from the family members, because I do, and I have heard several people report back to me that thank God the care community had a fall mat. Thank God the care community had a camera. They could see how my father fell or how my husband fell. Because when EMT comes to a care community, the first thing they're going to want to know, and the first thing want to know when they go to a home, what happened? Well, a person with dementia, if it's progressed and they're not aware, number one, do they remember falling? Number two, how they fell. Well, for EMTs, that information is critically important. So this is a very, very tough decision to make, but I think care communities do a wonderful job on disclosing that we do have this these products in the care community to monitor their safety. And yes, respecting their privacy. But again, what comes first, right? Do we respect their privacy or is it justifiable? Does it override that we're monitoring their safety? Does that override the fact that we are invading their privacy? So we have a poll on that. Sally, any comments?
Yeah, Karen says our local hospital has a 5-foot robot type device that monitors for falls. It looks like a minion and is very scary, I think, especially for a person with dementia.
Mm-hmm.
The nurses then don't go into the room but monitor from the desk.
So if I have dementia and I see that, I might get very aggressive. I might get very agitated. I might get very scared. And then all of a sudden I start acting out. And what do? Put them in restraints? What do we do? There's a perfect example of if we can identify the trigger, then there are other ways maybe we can handle those behavioral issues that come up, especially in hospitals, because we know hospitals often will put them in restraints. So Karen, thank you again for that information. Okay, so we'll do a poll on surveillance. In your opinion, how should care communities balance the use of surveillance technologies for safety and the residents' right to privacy?
Hey,
Okay,
I think we're still have a couple of folks.
okay.
Okay, I'm going to close down the poll and share the results.
Okay, so 42% said both safety and privacy can be balanced with the right technology and transparency. Then 31% involve residents and families in decisions about surveillance to ensure comfort and consent. And 23% use non-invasive technologies that respect privacy while maintaining safety, such as wearable devices. And there are 4% where prioritize privacy using technology only when absolutely necessary. Okay, thank you everybody for doing that. Okay, next we're going to do a vignette on therapeutic fibbing. 72-year-old woman with dementia repeatedly asks when her deceased husband will come home. Every time she is told the truth, she becomes distressed and grieves as if learning of his death for the first time. Her caregiver considers using therapeutic fibbing to avoid causing her more pain. How would you handle the situation? Again, there's 5 choices.
Okay, we're going to close the poll, and here are the results.
Okay, 19% said use therapeutic fibbing to reduce her distress. 23% said redirect the conversation to a pleasant memory or activity. And 38% said try validation therapy by acknowledging her feelings without confirming or denying reality. And 19% said consult with her family to understand how they would prefer handling the situation, balancing their wishes with her emotional well-being. Okay, so thank you for filling those questions out. Okay, so therapeutic fibbing, this is the last of the 6, is probably by far one of the most difficult strategies, techniques that family caregivers have a hard time accepting. So that we're all on the same page, I am going to define what therapeutic fibbing is. It is a compassionate communication technique where caregivers bend the truth a little or withhold information to avoid causing emotional distress, anxiety, or agitation in the person living with dementia. The main purpose for implementing therapeutic fibbing is to prevent the person living with dementia unnecessary emotional distress or mental anguish. However, the ethical issues are as follows. Is it okay to lie if the intention is to protect someone's feelings? Or is it better to tell the truth and potentially cause emotional distress and distrust? And we talk about in dementia care how important it is for us to enter their world, how important it is for us to meet them where they're at, how important it is to understand their reality and embrace their reality. So is it more respectful to align with their reality rather than forcing them to confront a truth they cannot process or grasp? And then caregiver discretion, kind of think this is key. This requires a lot of discretion and sensitivity. Often what I will say to clients is if telling the truth does not get a negative reaction, they accept it, they're okay with it, and there's no delayed negative reaction, then I completely think, tell them the truth. We're not creating an upheaval emotionally. However, if you tell the person living with dementia the truth, and it creates a lot of emotional anguish, mental anguish, they're distraught. And what also can happen that I do here in my private practice is that now it can cause friction and distrust that we're telling them the truth and the person with dementia doesn't believe it, that somehow you're saying things to them to hurt them. They don't believe you. They don't trust you. So it's a really fine line between entering their world, providing them with a response that hopefully is one that will not create emotional upheaval and mental anguish. So for families who have difficulty and really have a hard time wrapping their head around, implementing therapeutic fibbing, there are alternative choices and strategies. redirection, gently getting them to distract them and getting them engaged in an activity or a topic or something that we know they enjoy, that they love doing. Food works really well. Validation therapy, right? Validate by simply reflecting back, let them feel heard and understood, so we understand and we're meeting them where they're at. We're acknowledging their concerns. We're acknowledging their feelings. And then reminiscing is a wonderful way, I think, of connecting with a person with dementia. I love reminiscing with my clients with dementia because we get to talk about past experiences, and I learn a lot about them and what's special to them and what was memorable to them. And this can really be a nice bonding and a way of communicating and aligning with the person with dementia. And then we also have sensory engagement. We go into houses for sale, you go in and they've got, chocolate chip cookies baking. Boy, you walk in there and you have this, all of a sudden, this sense of, wow, chocolate chip cookies. There's something very soothing, very warmth. And we could try to, music, smells, touch. What are calming, soothing things, or giving them something to hold on to or to have that's very soothing and comforting. So we have alternatives to therapeutic fibbing, but it is a technique that is often used. But I do think that using it, we have to use our best discretion as to when it's appropriate and not to overuse it as well. So one more poll, therapeutic fibbing. Do you believe that therapeutic fibbing should be used regularly in dementia care to reduce distress?
Okay, I'm going to end the poll and share the results.
Okay, so 85% said it depends on the individual person's needs and emotional state at the time. And 12% did say therapeutic fibbing should only be used with family consent, ensuring everyone is aligned on the approach. So thank you, everybody, for participating in the vignettes and the polls. And I am going to share some closing thoughts, which are basically a summary of the key points for us to keep in mind. Dementia diminishes capacity, which affects the person's ability to give consent and make choices that are in their best interest. I do believe with dementia care, it should be primarily person-centered versus a one-size-fits-all. As you could see, we all had varying opinions. We all had differences of opinion. We learned different information from Karen and the other people who participated and shared with us information for us to keep in mind. There's not a black and white answer for everything and every situation. It's a very individualized, personalized, person-centered approach. I think it is important that we weigh the intent and desired outcome against the potential risks, and that we know what those potential risks are, and that we, again, in considering choosing quality of life versus quantity of life, here again, getting to know the families, understanding the person that they are caring for, what their wishes are, preferences are, getting to know that personal history, I think is invaluable in order to support the families in making the best decision with the best of intentions for the person that they are caring for. And always keep in mind that all behaviors are a form of communication. All behaviors do serve a purpose. And we kind of have to be a detective and try to figure out what are they trying to communicate to us. Because if we can figure out triggers that are causing certain behaviors, we will be more equipped on knowing how to deal with those behaviors. And then by all means throughout this journey, be aware of your own biases and of different cultural and religious beliefs. So thank you all so much for attending today's webinar and again, in participating in the polls and the vignettes. And for those of you who shared wonderful information in the chat. I am now going to turn this over to Sally.
Thank you. So Tami is available to help in a lot of different ways. You know, if your staff is burned out, if your staff needs some training, Tami can deliver that. If your families need counseling, if they need some coaching, if you need some counseling for families who are making the decision to bring their loved ones into your care community, she's available for that. She also does on-site consultations. She does cognitive and physical stimulation with for those who are living with dementia. So by all means, get in touch. Please advance a slide. And we want to say congratulations to Karen Faith Gordon, who has won a free 30-minute consultation. I will be in touch with you, Karen, and let you know how to retrieve that. And finally, you can find Tami's book on Amazon or Audible. I'm dropping the link into the chat. We so appreciate you're here, and I turn it back over to Tami.
Okay, so this concludes our webinar for today. And before we all log off, I just thought it would be a nice thing if all of us together could read this quote by Rosalind Carter out loud. And please join me on 3. 1, 2, and 3. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. On behalf of myself and Sally, I want to thank each and every one of you for the work you do, for the support and the care that you provide to families caring for a loved one with dementia. Thank you, everybody, again for participating and joining us today in this webinar on the 6 controversies in the dementia field. You all take care. Thank you so much for joining us.